In this session, we'll be covering lung failure. Fairly briefly, I'm not going to go into all the diseases that can cause lung failure, but we're going to deal with just a few of the common ethical dilemmas as you're called for a clinical ethics consult on patients with lung failure. Lung failure generally is anything that affects one's ability to breathe, the lung, that's the main function of the lungs. This could be the common things like chronic obstructive pulmonary disease, or COPD, which has a couple of different types: chronic bronchitis and emphysema. At least that's the older nomenclature. There are also diseases; those are usually diseases that are for patients that have smoked for a long time or been exposed to smoking over time. There are other types of lung injury: asbestos exposure, talc exposure, lots of other things. There are some special lung diseases, such as cystic fibrosis, which treatments are being developed for, but is still eventually terminal disease as of the recording of this video at least. And cystic fibrosis hits kids. It's a genetic disorder. There's also pulmonary fibrosis, which there's several types of pulmonary fibrosis, but one of the most common types that we see is idiopathic, which means we're idiots and don't know the pathology. In other words, it's we don't know the reason for the pulmonary fibrosis, but it is sometimes a rapidly progressing disease, sometimes slower. But there are these different types of lung failure. One of the other types of lung failure that we see is when patients are in the ICU and they have infection and they develop respiratory failure related to their infection or inflammation in their body, sometimes called bronchiolitis obliterans pneumonia, which is sometimes called BOOP, B-O-O-P. There are various other types of inflammatory injury to the lungs. There's also lung failure from aspiration, from the feedings or eating going in the wrong way, going into the lungs. The lungs don't like food, tube feeds or otherwise. And then often there's, like I mentioned before, in the ICU patient, often it's just really diffuse pneumonias. But I'm not going to deal with the specific types of disease and the ethical issues that may go along with some of the specific types. What I'm going to deal with was some of the common ethical dilemmas that you should know. In very brief, these last videos in the course are a lot shorter than the longer, more encompassing ones. So some of the brief clinical ethics considerations when you deal with patients with lung failure. One of the important things is often there's a question about do not resuscitate. Now, just as an aside, I haven't covered this before, there's a whole line of questioning about what nomenclature, what term should we use for do not resuscitate orders. The most common, when people say DNR, people know what you mean. Some people, and this is do not resuscitate. Well, some said, well, that sends the wrong message because we know from data that most resuscitation efforts aren't successful. So if you say do not resuscitate, it assumes that such would be successful. So they changed the nomenclature and said that we should see D and AR, and A being attempt. Do not attempt resuscitation. That somehow communicates, at least the proponents of this change say communicates, that this is an attempt, it's not successful. And even in their education, they may say, well, there is a low likelihood of success if resuscitation is needed. Some studies show as little as 30% success rate in hospitalized patients. Surgical patients do better. Medical ICU patients or patients with terminal cancer do much, much worse. A lot of patients with terminal cancer, untreatable terminal cancer, I think I've mentioned this before in other videos. If someone has a solid tumor that's not treatable and not curable and it's metastatic, the likelihood of them surviving a hospital stay, if they require resuscitation during that hospital stay, that is, their heart stopped, they can't breathe, and they require resuscitation, even if the likelihood of them surviving that hospital stay, in some studies suggest it's 0. Now 0 is not an effective treatment. That's in cancer patients. So this attempt of resuscitation, and what we're talking about resuscitation is chest compressions and rescue breathing, and then in the hospital you may get if someone has a shockable rhythm, it could be shocks during the resuscitation. Also use of medications and fluids and other things to try to stimulate the heart and bring the heart back and breathing back. Usually in the hospital, you're going to have intubation. That is, you'll have a breathing tube put into the trachea, and the patient will be put on a mechanical breathing device, a mechanical ventilator. Now, sometimes some of those medications can be done apart from resuscitation, or apart from the truest form of resuscitation. True resuscitation is when the heart when the patient's not breathing and they don't have a pulse. That's cardiopulmonary arrest, and that's what really we're talking about resuscitation. Some of the techniques and some of the technologies and medicines that are involved in resuscitation efforts can also be used in other times. For instance, if someone has an arrhythmia, sometimes we can shock people out of that arrhythmia, but just because it's a shocking technology doesn't mean that's resuscitation. Same thing if we're using certain medicines that stimulate the heart or constrict the vessels to cause a blood pressure. Those medicines may be used in a resuscitation in the event of cardiopulmonary arrest, but if they're used somewhere else, that doesn't mean that that's now a resuscitation. That's important to know. So this do not attempt resuscitation has gained some traction. Some say, well, that's not enough. What we need is not to assume that resuscitation and institutionalizing and medicinalizing death is the normal. We should say allow natural death. A-N-D, allow natural death. I think this is a real problem. We'll go into this more in clinical ethics too when we go into policies on do not resuscitate and approaches, but for the sake of this class, allow natural death I think says too much. There's a whole literature that patients who have a do not resuscitate order sometimes are discriminated against inappropriately. If someone has a DNR order, it means they don't get resuscitation, but it doesn't mean that they don't get other things like antibiotics and maybe hospitalization and other things. Those are not resuscitation. So various states, various jurisdictions, various hospital systems communicate this in different ways. I think the worst communication we can have is allow natural death. What that communicates is if I have a patient with a cancer and they get a urinary tract infection, that I should just allow their death, which is what decades of education around do not resuscitate orders has tried to prevent. This AND is coming from the hospice movement. I appreciate what they're trying to say. If you want to make comfort care DNR, which sometimes is a category of comfort care only, if you want to make that allow natural death, so be it. But it shouldn't be the same as DNR. So why do I bring this up with lung failure? Well, I've made these comments along the way talking about mainly cancer patients. But just as in heart failure, we have the best prognostication data in cancer, although it's getting harder and harder to prognosticate in cancer, as I think we will look back a decade from now on the way we categorize cancer and the way we treated cancer as fairly barbaric almost and simplistic, as the genetic information on cancer is just exploding. And you may have a patient with a cancer that if they get a biologic agent that works, it may give them years longer life, but it may only have a 10% chance of working. Well, that tells you that 10% of cancers may be vastly different from the other 90% of cancers that have the same type currently. So I think the categorization will change pretty dramatically and very quickly, and the types of treatments that are coming out are very different from the chemotherapy of the 80s and 90s. I think we're in a real transition time in cancer. But cancer remains one of the disease types that we have the best prognostication data on. Heart failure and lung failure is just harder to prognosticate. So in lung failure, it can be very difficult, especially in those chronic lung diseases like that are COPD related, chronic obstructive pulmonary disease, or smoking related. It's partly difficult to prognosticate in that patient population, the smoking population, because they often have vascular disease and can be at risk for stroke and heart attack or kidney disease as well. But if you just look at the lung prognosis, it's difficult at times. So specifically, as I mentioned, if I have a patient with metastatic pancreatic cancer that's untreatable, terminal, and they're in the hospital and getting sicker, if I tell them, sir, if you get so sick from your cancer that your heart stops and you can't breathe on your own, the likelihood of you surviving the hospital stay if we try to resuscitate you is 0. And we shouldn't do this because it's not helpful. That may be true for some cancers. Now that is a guiding way of communicating it. You also notice that the language says survival to hospital stay. I'm not saying survival of the code event. Sometimes the survival of the code event is the likelihood of that is higher. A little side story on that. I once was at a hospital. I won't say whether it was one I worked at or one I was consulting for, but it was at a hospital, and they bragged that they had an 80% success code rate. That is, that they were following the numbers and 80% of their resuscitation efforts were successful. And I said, no way. I said, no way. Let's do a tracer methodology. That is, trace one patient that was resuscitated. Let's just pick 5 of them. And I can guarantee you that that's not accurate. And so we did that. And what happened was patient number 1 came into the hospital, was sick, got sicker, the code was called, they were resuscitated, and they survived the resuscitation. And then they were moved to the ICU where they were coded again as soon as they got there, and they were resuscitated, and that was successful. They came back, and then the next day they had another resuscitation, and they came back, and then just hours later they had a 4th resuscitation, and again they came back, and then the team went to talk to the family and said, we don't think your loved one's going to survive, we don't think that we should resuscitate again. So another code was called, and after briefly starting the resuscitation, they said the family's allowed to do not resuscitate and the patient dies. Well, that's 5 resuscitations, and the first 4 were, quote, successful, and the 5th failed. 80% success rate. That's not a helpful way of assessing success in resuscitation. So often survival of the hospital stay is what we look at, because several patients that are dying will sometimes have cardiopulmonary arrest multiple times if we're doing resuscitation efforts. Usually that's in short days to hours that these multiple attempts happen. So survival of hospital stay is what I usually focus on, though the event may be effective. It's effective for a very short time usually in some of these cases. So going back to the guiding advice given to this terminal cancer patient, if I said that same thing to a patient with end-stage lung failure, if I said, ma'am, you have end-stage lung failure, it's predictable that your lungs will get to a state where you won't be able to breathe on your own, and if we put you on a mechanical ventilator, the likelihood of you surviving is essentially 0. Surviving the hospital stay is essentially 0. Well, that would be called a lie, because it's very difficult for me to know when a patient with lung disease will not be able to come off the ventilator. Sometimes we can predict that it will be long, slow weans off the ventilator, but it's very difficult to predict when the last one will be. What that patient would probably say is she'd look at you and say, well, it worked the first 4 times. Why won't it work this time? And that's I've seen that kind of conversation happen. So please know your prognostication data before you give any guidance in these requests or in these discussions. And for lung failure patients, in my experience, it's usually a different type of do not resuscitate discussion. It's not about well, you have less than a 10% chance of surviving the hospital stay, which is something we can do with other disease types. It's more about, when are you tired of going to the hospital? When is this burden of going to the hospital and being on a ventilator for 2 weeks, when is it too great? Is this the kind of time you want to spend for the rest of your life? This is where lung failure patients, this is where we get into kind of that quality of life, goals of care language that I generally don't like much. Now, most of the lung failure patients that I have cared for, they are willing to take resuscitation, especially for respiratory failure, which is many systems make a distinction. If you have respiratory failure only and not cardiopulmonary arrest, it's not resuscitation, it's elective intubation. So know that there's still this distinction. Cardiopulmonary arrest is very specific, and that's our full resuscitation effort. Many systems, many jurisdictions, especially those that are so-called pulsed states, pulsed is physician orders for life-sustaining treatment, sometimes called MOLST, to satisfy the politically correct folks that don't like egocentric physicians like me. That's medical orders for life-sustaining treatment. Those forms generally, there's different forms depending on the state, make a distinction between resuscitation from cardiopulmonary arrest and elective intubation from respiratory failure, or even emergent intubation from respiratory failure. So know, if you're doing a do not resuscitate talk, that there's are these distinctions. Usually we'd cover both cardiopulmonary arrest and respiratory failure in these patients. My experience is that it's really about, when is enough? When are they tired of being in the ICU? When is this burden of hospitalization greater than the perceived benefit? I still like to use that benefit burden language as much as possible, and not the quality of life language. But the futility in lung disease, it's much harder to show because often the patients can have a prolonged hospitalization, a prolonged respiratory failure with prolonged mechanical ventilation, but it's not always clear in advance when that is going to be the last one. Sometimes along the path it is. Okay. So so that's one caveat. Another is that patients with lung failure, these are the patients that when they're in the mechanical, when they're in the medical ICU, or the surgical ICU, these are the people that we would withdraw ventilator care from. Many times, withdrawal of the ventilator, sometimes they have lung disease, sometimes they don't. Some people are on mechanical ventilation because of other issues like neurocognitive devastation from a stroke or something, or a horrible infection that causes hypoactive delirium and they're on mechanical ventilation, or seizures, or something else. But many of them do have lung failure. And when you withdraw, the way that mechanical ventilators are withdrawn is actually just to take the tube out. It's not dialing down. Okay, it's not dialing down the oxygen, dialing down the respiratory rate. That is a very active way of doing things. So it's often just taking the ET tube out, the endotracheal tube out, and putting either blown air or sometimes even oxygen over the trach or or nasal cannula, or even mask. I don't like masks much, but so that is. Now we discussed previously, when you take the endotracheal tube out, it's naive for us to think that we're turning to a natural state of disease, and that there's all kinds of things that happen with this pressure change from having positive end expiratory pressure, PEEP, that is what the ventilator gets when it keeps the alveoli open throughout the respiratory cycle. That goes away, and you can have all kinds of changes in the lung dynamics based on that. However, like I said before, most of these patients would have died long before without mechanical ventilator assistance. I think it is ethically permissible, this is my opinion, I think it's ethically permissible to remove the ventilator, in part because if they would have died without the technology long ago, now we're just putting aside that technology and allowing death. I think there is a distinction that is allowing death, and it's not trying to hasten death. The other is, of course, that patients have the right to refuse, which we talked before, and their proxy can refuse for them as well. This can include withdrawing the mechanical ventilator. One other caveat in lung failure, though that we see this most commonly in brain failure, but we see it sometimes in lung failure too. There's this critical time in the first 2 weeks of ICU care that ICU teams really get nervous about trach and peg. That is, having a tracheostomy, a hole put in the trachea directly, and taking out the intratracheal tube, and having a G-tube feeding instead of having a Dopphoff tube or a nasogastric tube that is a tube and goes through the nose into the stomach for feedings, or just using IV fluids. So there are data suggesting that there's an optimal time to do this. The earlier the better when it comes to trachs generally. But we have to think about the reason why. ICU teams, because they will get very rote in the routine of when they need to ask this question for optimal care, for best practices, sometimes forget why we do this. And often one of my roles is to remind them why we do this. There's not that much of an importance with PEG, other than some ways that you can put in a G-tube directly into the stomach or duodenum. Some of the methodology of doing that will decrease some of the regurgitant flow and decrease the risk of aspiration. Now you can still aspirate with a G-tube of any type, so there is no foolproof G-tube to prevent aspiration, and we don't do autopsies all that often anymore. But I think if we did, we'd be astounded with how many patients have tube feeds in their lungs. I requested autopsy on several patients that I was caring for at a time in my medical past. The number of them that had tube feeds in their lungs was just astounding and not predicted in any way. So G-tube there is some reason to have that, but it's not that strong. And tracheostomy, the main things we're talking about here is one, there are little bones in the voice box called the arytenoids. The endotracheal tube can cause arytenoid disarticulation, and so there's swelling of the larynx, the voice box. And it can cause problems if you have an endotracheal tube through the larynx for a prolonged period of time. Okay, well that's important, especially if you think someone's going to recover, but is it that important? They do recover. The other thing it can cause is prolonged intubation can cause infections in the sinuses and maybe increase infection elsewhere, but it's not such a large risk that you can't be patient for a few days or even a week as a family decides on whether they do this trach and peg or not. Often you have a team, they decide now's the time to decide whether it's time to cut bait or keep on fighting, because it's time to decide on the trach and peg, and you get this kind of high pressure sales. I would just say don't do that. Don't do the high pressure sales. Reassure the team you have time. Yes, it's best practices to trach and peg in a certain number of days after intubation. And data are change on that, so I won't quote the number of days, but it's usually in the first 2 weeks. The earlier the better is what the data suggests, but it's not such a huge risk that you can't wait. Other issues in lung failure include we had a lecture on the double effect. And how it was probably not important in pain and symptom management. Double effect was basically rarely talked about until the modern hospice palliative care movement, and then it was talked about quite a bit as a defense for a defense for using morphine and morphine's cousins in pain management in the dying, even though morphine may hasten death. Now, I said before, the data suggests that it's very unlikely for morphine to hasten death. if it's appropriately prescribed. However, and I also said that usually what you're dealing with morphine in pain management is the dose difference between death and symptom relief is walking a wide plank, not a tightrope. Some people, the difference between pain management and sedation may be more of a narrow plank. Rarely, sometimes it is a tightrope, but usually it's a narrow plank. But in lung failure, the difference between shortness of breath and this experience of shortness of breath, which we call dyspnea, so the difference between dyspnea relief and sedation can be very fine. And the difference between dyspnea relief and death and hastening death may be that narrow plank. So that double effect argument, even though I have problems with it from a theoretical standpoint on knowing our intent and many of the things that we covered before, is more appropriate for dyspnea relief. Generally, treating dyspnea with opioids and other sedating medicines like benzodiazepines or other medicines there's plenty of data that it's safe and effective and that doesn't hasten death, but I can tell you it may. When could it? And this is more medical, but I want you to know the medical side of things because this is often missed. The problem with dyspnea relief is that the most common dyspnea approach that I've seen consulting at various hospitals is I'll see if respiratory rate is greater than 20, then give morphine. This order is really, it shows incompetence. It's so common, but it means that people don't understand what dyspnea is. Dyspnea is the subjective feeling of shortness of breath. Respiratory rate of greater than 20 is tachypnea. It just means it's fast. And if physicians try to control the rate of breathing in a patient, then they can hasten death. For the physicians and nurses in the audience that do this kind of care, if someone has an acidosis and is breathing off and is trying to compensate with a fast respiratory rate, or if they're hypoxemic and they're trying to compensate with a fast respiratory rate, and you're blunting that more and more and more and more with opioids, then you're likely going to hasten death. I have had many lung patients who I'm seeing in clinic, and they look like this. And I say, you look like you're uncomfortable. And they say, no. And they look like they're in distress. They're breathing so fast. Their nose is flaring a little bit. I mean, their muscles are coming up. Their stomach may be retracted. They look like they're in respiratory distress because they are chronically, and their brain has habituated where they're not uncomfortable. I mean, they can't do anything. They just want to sit there or lay there, but they don't have dyspnea in the same way. And so if you have a patient that's sitting there breathing fast, that doesn't mean you have to give more and more and more morphine until they're breathing less than 20 respirations a minute. That's a problem. So get with your palliative leader, get with your pulmonologist, and educate your hospitals on this part. If you're seeing these orders, this is a problem. The goal for dyspnea treatment also is if you do a Likert scale. Some people debate the pronunciation of that name. I'm not going to worry with that. But if you use a 0 to 10 scale for dyspnea, what you'll see with the opioids and benzodiazepines and other medicines is that it just decreases the dyspnea rating a little bit, maybe an 8 to a 6. Okay, so not a huge decrease, but it's substantial. The thing that will change in lung failure patients is how far they can go. Their exercise tolerance. And the difference between going from being bedbound and being able to sit at the side of the bed or use a bedpan, or going from a bedpan to a bedside commode, or a bedside commode to your own toilet, or just being confined to a room in a restroom, to going to the living room, or going to the front porch, or going to see a neighbor, or going to your clinic appointment on your own. All these things are really drastic quality of life measures. I tell my palliative folks that that's what they should be monitoring more than dyspnea scores, is how far can you go? What's your exercise tolerance? Because most of the data suggests that it's the exercise tolerance that changes with very low dose opioids, very low dose benzodiazepines. The higher the dose, raising the dose doesn't seem to work. Okay. Other issues with lung disease and lung failure include things like lung transplant and issues of home mechanical ventilators and the like. The lung transplant and transplant in general is it has so many organs and so many issues that we're not going to cover organ transplant in any depth in this course. There are a lot of potential. We'll just hit some glancing blows at issues that arise in transplant. One of the important issues in lung transplantation are some of the patient can't smoke, and the patient can't use any drugs. Some transplant centers, they can't be on opioids, which I think this is really troubling, but some transplant centers this is true, and in some transplant centers they cannot have a DNR order. That's troubling too, because most patients that are on the lung transplant list will never realize that lung transplant, so that they don't want to be resuscitated. But if they could get a transplant that they that they would reverse that and get the transplant. I think this is really problematic, and some centers have changed this or considering changing this. I think they should. The not smoking is interesting too, because it takes a number of years to develop lung disease from smoking, and we'll mention this in one of our later sessions on the God Committee, whether we make value judgments on patients in health systems. Home ventilation is just not very common. It's not. You'll see some articles out there, but it's usually not offered as an option because it's not readily available. There are long-term acute care centers that do long-term ventilation and acute care for patients that need ongoing ventilation. In some skilled nursing facilities will also do this kind of care, this long-term ventilator care. Home ventilator care may become simpler and may be done more. I just don't see it as a common option that's offered currently. All these things can come into play. The experience of being short of breath provokes anxiety. Not anxiety, and I tell patients you don't have anxiety. Anxiety is a fear of the unknown. What you have is fear. You're afraid you can't breathe. And so many of these patients, somewhere along their disease trajectory, will take on some sort of stigma of a psychiatric problem of anxiety or panic. If you want panic and anxiety, be short of breath from lung disease. Don't get enough oxygen, don't get enough air. So those are sometimes troubling responses that you may have. One of the other challenges that we have with lung failure patients is many of them want to smoke in the hospital. And smoking and an oxygen tube can often create a flamethrower. I've had several patients burned from smoking with their oxygen. And we often just have to babysit adults in this way and say, no, you may not smoke in this way. Now, some people say if you're dying and if you got them, smoke them. There's some data suggesting that if you stop or reduce smoking, then you have some symptomatic improvement, even in patients that are terminally ill. So those are important. I would prefer I'm currently at a system that doesn't allow smoking on the premises, and so what it does is it reduces families and patients to sneak behind some dumpster somewhere and smoke. I think that's really undignified. I'm still for having designated smoking areas that are safe and have good ventilation and all that, something like some airports have. But unfortunately, the growing trend is that that smoking becomes the unforgivable sin. And I think that sends a bad message to our patients that smoke, that we don't care about you. You did this to yourself, and we're going to punish you and make you go smoke by the dumpster. I think this is a real problem. We'll touch on that more in when Clinical Ethics 2, talking about hospital policies. So I think this covers most of some of the major concerns regarding lung failure, mechanical ventilation, and oxygen therapy, and things like this can be very helpful, but it depends on the prognostication at the time. Treating dyspnea, I think, is helpful. It's shown safe and effective, but there is more danger as far as potentially hastening death or causing sedation in treating dyspnea than there is in treating pain. And then we had this other DNR issue that if residents or fellows or attendings or clinical ethicists get into a habit of giving very grim prognostication data to patients, and they do that to a lung failure patient, it may not be accurate. So I think this covers it, and I look forward to our next session. Thank you.